Hi, my name is Polly Pittman, and I direct the Fitzhugh Mullen Institute for Health Workforce Equity at the George Washington University Milken Institute School of Public Health. Welcome to the sixth in the Mullen Institute webinar series on emergency health workforce policies to address COVID-19. This session builds on a prior webinar entitled Why Occupational Standards Matter, which you can also find on our website. Today, we're going to examine a related but different question, which is whether during this period of crisis, health personnel have the right not to work when they feel their health or their family's health is in danger. As I mentioned in the prior webinar, the WHO has issued a list of 13 worker rights specific to the COVID-19 crisis. I want to read a few of those which relate directly to this topic. The WHO suggests that employers must allow workers to exercise the right to remove themselves from a work situation that they have reasonable justification to believe presents an imminent and serious danger to their life or health. When a health worker exercises this right, they shall be protected from any undue consequences. Second, honor the right to compensation, rehabilitation, and curative services if infected with COVID-19 following exposure in the workplace. This would be considered occupational exposure, and resulting illness would be considered an occupational disease. Third, provide access to mental health and counseling resources. And fourth, enable cooperation between management and workers or their representatives. So we know that not all employers agree with these principles, and that's not actually the topic of our webinar today. I'd like to focus instead on what's going on in the hearts and minds of the frontline health workers. In particular, how are the frontline health workers balancing their professional duty to serve and their personal duty to keep their families safe? And secondly, beyond the question of personal protective equipment, which we addressed in an earlier webinar, what policies and practices would help alleviate this tension? Things like childcare, housing, hazard pay, and even healthcare coverage are examples of ways that governments can help alleviate this terrible tension between professional and personal duty. To talk about this, we have three panelists today who hail from very different parts of the country, institutional settings, and different professions. Dr. Sonal Batra is an assistant professor of emergency medicine here at GW. She's a member of the Mullen Institute and leads our work on the social mission of health professions education. She's also a practicing ED physician grappling with these issues at a personal level. Dr. Cheryl Taylor is a nurse educator. She's the Jewel and James Prestige Endowed Professor at the Nelson Mandela School of Public Policy and Urban Affairs, Southern University A&M College in Baton Rouge, Louisiana. She chairs the graduate nursing programs there. She's also the National League of Nurses consultant to the National Student Association and a lifetime member of Nation Black Nurses Association. In 2006, she served as a member of the Katrina National Justice Commission. Lastly, Angelina Del Rio Drake is the COO of an organization called PHI, which advocates for the direct care workforce. Drawing from her own experience as a home care worker, Angelina has launched several projects to improve job quality for direct care workforce. She provides technical assistance to direct care demonstrations across the country in the areas of upskilling, advanced roles, and care integration. Sonal, I'd like to start with you. Could you set the stage for us by sharing with our listeners the basic concept of social mission in education and what it means in terms of the responsibility of practitioners once they graduate?
Sure. So I'm going to take the definition of social mission from an organization called the Beyond Flexner Alliance. And they've defined social mission as the contribution of a school in its mission, programs, and the performance of its graduates, faculty, and leadership in advancing health equity and addressing the health disparities of the society in which it exists. And the idea is that if you promote health equity early in the educational process, you're going to recruit students who are interested in this. You're going to enhance their understanding and their skills and ability to advance health equity going forward when they become practitioners. I think what the ideal practitioner looks like when social mission really becomes embedded in the educational system is someone who both sort of at the individual level and at the public health and community health level is thinking about issues like social and structural determinants of health, issues like access to care and understanding health systems, collaborating with the community to deliver excellent care to everyone, but also that gives every patient a chance to achieve optimal health no matter what their background is, whatever their social situation might otherwise suggest in terms of their health outcomes.
Thank you, Sonal. Do you think about sort of regular times differently than times of crisis like we're living now in terms of the social mission of health professions?
Not really, actually. I mean, yes and no. I think that both in regular times and in this time, we still have an obligation to, in our everyday work, be trying to promote health equity. I think the way we do that might look a little different in regular times versus crisis times or pandemic times. I think that when we think about the challenges that we face day to day with addressing health problems in patients who are experiencing homelessness or incarcerated or who have other significant barriers to achieving optimal health, the way we might do that in this current setting might be a little different. The health systems and government organizations and personal care even that we provide might vary. But I think in terms of the overall approach to, being a doctor in my particular case or a healthcare practitioner, I don't think it's terribly different.
Okay, I'll come back, Sonal, to you with some more personal questions about how you're sort of weighing these two important needs of the personal and the professional. But I'd like to turn to Angelina now. Angelina, could you tell us a bit about what you're hearing from the direct care workforce about their everyday realities during the COVID crisis?
Certainly, and I think it's important to first understand that the work that's done by the 4.5 million home care workers and nursing assistants in the US was precarious work prior to the COVID-19 pandemic. These workers are critical to the safety and well-being of millions of people across the country, but they're paid poverty-level wages, minimum wage, or just a few dollars above. Some struggle to obtain full-time regular hours. They don't have employer-sponsored benefits, including paid leave in most cases. They're poorly supported on the job. This is particularly true for home care workers whose work is mobile and isolated. And in most cases, training standards are fairly minimal. There is a federal minimum for home health aide and certified nursing assistants, and it includes some infection control competencies, but the most popular home care title, personal care aide, has no federal regulation, and states really vary from 0 to around an average of 40 hours of instruction. And further, these workers are poorly integrated with healthcare and social service delivery systems. So because direct care workers are so often undervalued, underprepared, and underutilized, the challenges that they face have been significantly deepened in this pandemic. Direct care workers are less likely to have access to personal protective equipment. Understandably, acute care shortages have been the priority with these supplies, but we're not really recognizing direct care workers as critical to flattening the curve for COVID-19 infection because they can keep high-risk clients, older adults, people with serious health conditions out of the hospitals and emergency departments that are being overwhelmed in the COVID-19 crisis. These workers also face a unique economic vulnerability that compounds their risks and compounds the risks to their health and their family's health. When you're making around minimum wage, it's much more difficult to stock up on groceries, cleaning supplies, or to afford childcare when schools are closed. It's also harder to source your own personal protective equipment when your employer or state Department of Health cannot provide it. We've heard from direct care workers across this country that they feel like they're on their own. They're on their own in managing risks to themselves. They are an essential workforce. They're often going to work on public transportation, seeing multiple clients a day, but they also feel on their own in minimizing the risks to the clients that they work hard to protect. So they're getting little, if any, clear and consistent guidance around how they can minimize risks in this pandemic. We're further hearing from their employers that they're not getting clear information from state departments on health on what to do to mitigate risk when they can't get personal protective equipment and other supports. So again, it's really critical that these workforces are recognized as essential workers, because in places like New York, that means they can get access to government-sponsored childcare and other social supports. But we have to recognize that they're healthcare workers, they deserve quality training, they deserve access to relief programs at this time. And because these workers are not just economically marginalized, but often also face racial, ethnic, and geographic discrimination, that they don't have as much of a voice in the public health and workforce advocacy conversation that's going on right now surrounding coronavirus.
Thanks, Angelina. It's an incredibly important perspective. And obviously the situation of the physician workforce is quite different from the direct care worker workforce. And that's precisely why it was so important to have you both on this panel. I wonder if you could talk a bit about ways that the direct care workforce could be better supported, what kinds of policies you think could be in place, and then we'll move to nursing, which is yet a third very different segment of the workforce, and talk about ways to support nurses.
Great. So, overall, we need employers, workforce advocates, and public health officials to care for paid caregivers. This includes those who are continuing to go out and do their job, as well as folks who, because of their own COVID-19 related illness or illnesses in their families, or their own family caregiving responsibilities, are unable to work. It includes folks who, we're seeing some workers choose not to go into the field, but we're also seeing direct care clients afraid for their own safety and refusing home care services right now. So we need to make sure that direct care workers can continue to be paid at this time by their employer if possible, whether it's an agency, a family, or an individual directly employing them, that they're offered paid leave, and that they're included in state emergency paid leave policies, that they can be connected to social supports and community aid for meals, childcare, transportation, and direct financial relief, and that these workers, if they are unemployed, can access unemployment insurance. There are many direct care workers who are employed as 1099 independent contractors, and they're going to need support in how to access the unemployment insurance system at this time. And then at the federal level, making sure this workforce is explicitly defined as a healthcare workforce so that they can have relief in social supports and other assistance at this time, and making sure that local health departments give them clear and consistent guidance that is contextualized to the home care and nursing home environment, and that also accounts for not just physical safety, but emotional well-being.
Thanks, Angelina. It'll be interesting to circle back with Sonal about ways that the physician workforce could play a more active role in supporting the direct care workforce, because clearly we need to connect these dots. But I'd like to give Cheryl an opportunity to tell us a bit about what's happening in Louisiana right now. I know it's a particularly important day. Today is the day actually when, at least in New Orleans, the there was expected to be a spike in the cases of COVID-19. So it's a stressful day for you, Cheryl, I know, and I'm appreciative of the fact that you've made time for us. Can you tell us a bit about what you're hearing from nurses, particularly in Louisiana, but around the country as well?
Muted. I have to unmute. Okay, can you hear me?
Yes.
First, I have to convey a collective message to healthcare workers all over the country that's coping with this COVID-19 humanitarian crisis. And that is to say, thank you for having the courage and for helping us get through this. And we love you. We love what you are doing, and we support your rights to have health for yourself. Now, with that said, what we're hearing is similar to what happened with Katrina, that we have a country that has a big heart and people step forward, whether they are volunteers, and in the case of Katrina, the volunteers came everywhere, but volunteers, professionals like nurses, physicians, home care workers. And what we discovered then, and also what we're seeing now, is there is such a rush and a focus on taking care of the other, the patient, until there is sometimes neglect of attention and space for people to take care of themselves, and almost feeling guilty about not going to work, not going in what I would call harm's way. And why I say harm's way is, if as a nurse I'm immunosuppressed, if I'm not in good health, if I have health challenges, and I go in an environment where I may be at risk for getting the disease or carrying it or becoming a vector of it and bringing it to my family, then that makes the problem exponentially larger. And so we're practicing social distancing here, and but recycling personal protective equipment, if you don't have it, as nurses, you know what we do. We try to make do and adjust and do the best with whatever we can. But I do have an appeal to anyone that's managing healthcare workers. And my appeal is, remember, healthcare workers, that is a title, a role, a label that they've taken on, that they're living. But first, they're persons, they're members of families, they are human beings that have health needs, and they deserve to be cared for, not as patients, but they deserve compassion as we have compassion for our patients.
Thank you, Cheryl. It's an interesting way of bringing together these two issues of professional duty and also of self-care that I think Angelina also brought to the fore. I wanted to turn to Sonal for a moment, if I may. Sonal, these perspectives that are obviously urgent needs of the entire workforce, but particularly urgent for direct care workers and for nurses as well. What role can physicians play in supporting their colleagues in their demands and in their call for better supportive policies, particularly for the direct care workforce? And how are you seeing this play out in your own workplace, where different social classes, different race and ethnicities within the workforce may have very different lived experiences and access to services?
I think in terms of the role of physicians, I think that Angelina and Cheryl put it really well in talking about the kind of collective challenges that we're all facing, but also the differences in the challenges that we're facing and that we faced even prior to the current pandemic. I think that, I know we might talk a bit about the duty or obligation to work or not to work. And I think that while every physician has their own unique situation, every healthcare worker has their own unique situation, sort of as a whole, as Angelina pointed out, people who are working in home health and other fields have, just are severely undercompensated for what they're doing. And because of that, don't have access to the same resources and choices that I might as a physician in a relative position of privilege, which could be to not work if I choose not to and not have that result in my family entering deeper into poverty. So I think with that said, what we can do, and I think what we are doing to some extent, probably could continue to do, is right now, healthcare workers and maybe physicians in particular, but also nurses and other commonly recognized healthcare workers have a podium in a way that we didn't quite before. And I think that we should be using that podium to advocate for all of us. I think that there are places in which the feeling of the situation is more acute. I think about where I work in emergency department and in intensive care units, where there's a very palpable change, particularly in some parts of the country, that makes it a very unsafe place to work, where you have many patients with COVID-19 all in one place. And when there's a dearth of equipment in those settings, it is needed, but it's also easy for the public to really get that. But I think, as was pointed out earlier, when you have this whole entire health workforce that's spread over people's homes, that's spread in nursing homes, and that are themselves at risk and that are putting their patients at risk, that all contributes to more people ending up in the emergency department and ending up in the ICU. So both from the perspective of really respecting the rights of our healthcare workers, but also from the larger societal level of keeping this curve flat, I think that we should make sure in our advocacy that we're sort of thinking beyond just the acute care setting, and going broader in what we're talking about.
Thanks. Cheryl, when you think about the nurse workforce, obviously, perhaps a little over half of the nurse workforce is in hospitals, and among that workforce, about a fifth are over age 55. Many have underlying health conditions. What are the policies and programs that those nurses need to be able to feel safe beyond the issue of protective gear, which we've talked about quite a bit in a prior webinar? Did any of the policies and programs that Angelina mentioned apply as well to nursing, and are there things where nursing and frontline workers could partner in terms of advocating for these resources?
Absolutely. As a matter of fact, one of the challenges that we're having right now, because there's a demand for so many more nurses, and so I think not only hospitals but staffing agencies should have policies that support and provide a supportive environment. For example, in the military, in the history of the military, there's sort of there are categories of service where, you know, you serve in this area if this is what you can do. So if a nurse has some health challenges and she has to work for a living, then to just automatically convert a unit from a cardiovascular unit to an ICU unit, and everybody there has to work that unit, to automatically take a primary care MP and say, well, okay, I know you're an MP, but we're not doing that right now. Everybody has to take care of COVID patients in ICU. That's not a supportive way to help our healthcare workers, our nurses. So what should be happening, I think the employee health department is a good place that could provide infrastructure and support for nurses. They could have housing. There are nurses right now that are afraid to go home because they don't want to take the possible risk of their families contracting the virus. So they put their monies together and rent a house. Free housing, childcare, grief counseling. Can you imagine how much death and dying nurses are having to witness and experience in this COVID-19 humanitarian crisis? But you have to go through your shift, do what you do, come back the next day after having lost several patients the previous day. Grief counseling, just available, those kind of services available could be a tremendous help to all the healthcare workers. And then there's this issue, because of the nature of the disease, family cannot visit the person on the ventilator because, you know, et cetera. There are limitations around visitation. So families, and remember, nurses and healthcare workers are members of families. So they're witnessing this where the person might be dying and there's no one there to be with them during that time. And so I think another thing that nurses as healthcare workers could do is be that person that holds the client's hand and be able to convey that to the family who is so stressed out that nobody's with this person. So one of the lessons that was learned from Katrina, the disaster, was that we need to collaborate to create a better disaster preparedness model for this country. And a lot of good things have happened. And so we need to collaborate to have a better response to global pandemics like this one. And I think all healthcare workers need to have a safety net to help them navigate in this very, very, very stressful role that they have in a crisis like this.
Thank you. Very eloquently said, Cheryl. Angelina, I'll give you the last word. This notion of collaboration with other sectors of the health workforce. Are there ideas about how that could be done more effectively to, as you said, help elevate the voice of the direct care workers? And are there particular thoughts that you have around this tension between the right not to work, the need to be paid, obviously, and also to remain healthy and safe and protect your family?
Yeah, so, fundamentally, we need to make sure that when we are calling to support healthcare workers at this time, that we include all healthcare workers, including those who work in our homes and communities, and making that distinction there and positioning the work that's done in the home or in a nursing home, maybe one level upstream from the acute care setting, but it really can help flatten the curve, help people who are at high risk to stay home. And it's important just narratively to include direct care workers in that conversation. And when we're thinking about what it means to value this workforce overall, over time, integrating direct care workers into the delivery of healthcare, putting them on health teams, interdisciplinary health teams, and training not just the direct care workers, but the other practitioners on those teams and how to value, listen to, and work with direct care workers who provide the majority of paid hands-on care for people who receive long-term care services, and often with additional training can observe, record, and report information about how their clients are doing. So there are ways to do this, I think, more systemically, but at this time of urgent need, it's really just including that workforce in these calls for better working conditions and better compensation and narrative inclusion, stories that are coming out. When it comes to deciding whether to work or not, I think this decision is considerably challenging when you're making such low wages and you are relying on hourly work. So you're balancing, as a direct care worker, your client's need for care and support. Often clients have very serious physical needs and they cannot go about their daily activities without a direct care worker. But you have to balance that with your own health, financial needs, and your family's well-being. I think when you're making at or near the minimum wage, it is harder to turn down cases. And for those who choose to do so, we're not giving them support on how they can do that safely, making sure that their client receives additional support somewhere else, or how to make sure that they don't fall into financial ruin by not working when they feel unsafe. So literally every risk-bearing factor that goes into making an assessment about whether to work right now is magnified when you're making low hourly wages. So that's risk getting to and from work, protecting yourself at work, and protecting yourself and your family at home. So again, even though they're not in hospitals, recognizing direct care workers and recognizing that the challenges they face are really compounded due to the lack of wages, support, and overall invisibility that this workforce faces.
Dr. Pittman, may I say something about standards?
Sure, please do.
We're in a time where a lot of regulations and standards are being relaxed, and because of the nature of the crises. But just because standards are being relaxed, that doesn't mean we should throw ethics and morals out along with that. So I think it is imperative for managers of healthcare workers to maintain the integrity of the intention of the standards. Standards were set in place, whether they're legal or clinical guidelines or whatever they are, they're there based on evidence of us knowing what works. And so the idea of waiving and relaxing the rules, I am I think that's important because we're rushing to solve a problem. However, in the process of that, we still have to have our heart in this, and we still have to maintain some integrity about the standards. So for example, if I'm sick and I know my health status is not of such that I should report to work, then my manager or any manager should understand and support that, because that in the long run complies with the integrity of the standard.
Thanks, Cheryl. Absolutely. Sonal, I'll give you then the last word since we've done one more round, and I feel as though you've had a little less time to talk about also your own personal balancing of these different needs.
Thank you. Yeah, I think Cheryl actually just hit on a lot of what I wanted to say, which is that while we, I think all have expressed that there are many reasons that healthcare providers feel an obligation, a duty to the patients that we take care of, especially in situations when there's really, no clear answer as to who would do that without us. At the same time, it's not infinite. And I think that there is, a reciprocal obligation of our employers and of society as a whole to make sure that we are adequately protected. And I think that there, for many people will become a time when that lack of adequate protection goes past the point of being comfortable. And I think that that balance is important to remember, that it can't just be unconditional, because then, where do you draw the line of, how much risk that we're willing to put these people, us, at, and our families, who which is the largest source of stress for a lot of my colleagues and I, which is, some of it is around, will we get sick? I think that's more of a concern for people. Fortunately, I'm relatively young. I don't have medical problems, but I have a 1-year-old and a 2-year-old at home. And I think about that, and I think about the risks and take cautions for that. And so I think that, we have to recognize that finding that right balance for this current pandemic is going to be important. And it's also going to set a precedent for future crises, whether that's hurricanes or infectious diseases or whatever we know that at some point in the future is going to befall us.
Perfect. Thank you so much, Sonal. I think well said. The challenge is to find that balance and the lessons on how to create policies and programs and management styles that support that balance. And it's very interesting to think about the three of you in such different places within the healthcare system experiencing this differently, but there is nevertheless a challenge of finding the right balance no matter where you sit within the healthcare system. So thank you so much, Angelina, Sonal, and Cheryl, for joining me on this webinar.
I have a message from Louisiana to everyone. COVID-19 may be in the air, but love is also in the air for healthcare workers all over the globe.
Thank you, Cheryl. You're here. Bye-bye. If you all want to. Hopefully that if you all want to stay on for a second, we can debrief.